One of the greatest challenges we face in multiple myeloma is the fact that literally all patients have a delayed diagnosis. What I mean by that is the time between their signs or symptoms and the actual diagnosis. We see this quite universally in myeloma, partly because of the fact there really is no absolute single defining or pathognomonic sign or symptom for myeloma. So most patients, unfortunately, experience delays as they are undergoing their pain or the fatigue or the anemia, whatever it is that they have as their presenting sign and symptom over a period of time. Recent data has actually demonstrated to us that the average myeloma patient sees their primary care team 3 times with signs and symptoms consistent with myeloma before myeloma is suspected and then ultimately confirmed. Lastly, I think a very important point to make here is that although the average patient does have a delay in their diagnosis and often has multiple medical visits before the diagnosis is suspected and confirmed, that this is even longer in certain populations, particular minority populations like the African American population, where there can be confounding diagnoses, where there can be less access to certain diagnostic testing and even general health care that even further delays the diagnosis of multiple myeloma. One of the challenges in diagnosing myeloma is that there is an extensive differential diagnosis. Patients don't come in with a sign on their head that says, I have myeloma. So more often than not, they tend to be somewhat vague symptoms early on. The 3 most common presenting signs and symptoms of myeloma are fatigue, anemia, and bone pain, and typically back pain. And these, of course, are very common things. The primary care provider sees all 3 of those things on a regular basis. So we endeavor to help the primary care world, and we wrote a paper to specifically help discriminate the nature of these signs and symptoms that would point you towards myeloma as opposed to other things on that differential diagnosis list. So that when someone has anemia, when someone has bone pain, when someone has fatigue, what are the other things that we should be looking for that may include renal insufficiency, proteinuria, or even just an elevated protein in the blood, that there may be neuropathy, and these things may point us in the direction of multiple myeloma. Part of the challenge in that, of course, is confounding diagnoses, of which perhaps the greatest is diabetes. And again, diabetes is more common in certain populations, such as the African American population and the Hispanic Latinx population. Because indeed, many of the signs and symptoms of diabetes match those of multiple myeloma. And we've learned over the years, as many of our myeloma patients have ultimately been diagnosed with myeloma, they look back and say, for many months, they thought that my anemia, my renal insufficiency, the proteinuria that I had, the neuropathy that I had was related to the diabetes and not to another diagnosis. So for the primary care provider, one of the things to remember is don't always attribute the classic signs and symptoms of diabetes to only diabetes, but in particular higher risk populations, such as the African American population, in whom we see the diagnosis of myeloma twice as commonly, that it's important to think about the right diagnostic tests to discriminate them from having diabetes or other cardiac and renal issues to genuinely having multiple myeloma. So when myeloma is suspected, it really is important to do the right tests to suggest the diagnosis that can ultimately be confirmed on a bone marrow test. And more often than not, those initial basic tests are done, which would be a CBC or a complete blood count so we can see someone's CBC profile. The key biochemical testing that would include a total protein, a calcium level, and their kidney function or creatinine. But then very importantly, and perhaps the most important point I can make, is the myeloma-specific protein tests that are necessary. The triumvirate, the holy trinity of obtaining a serum protein electrophoresis along with serum immunofixation and the serum free light chain assay. That serum free light chain assay is particularly important because we know that roughly 20% of myeloma patients will have a negative serum protein electrophoresis. And for many years in the primary care world, and frankly in the specialty world, when myeloma was considered people would just order that SPEP or the serum protein electrophoresis. And that's a great first step, but we're going to miss at least 20% of patients if we don't also do the serum protein electrophoresis along with it doing that serum-free light chain assay. So in summary, a CBC, the basic biochemical profile, serum protein electrophoresis with immunofixation, and indeed the serum-free light chain assay. We know when those tests are done, we can almost exclusively know if the patient does or does not have myeloma, which is then ultimately confirmed with a bone marrow test as the quintessential diagnostic criteria.